Hi, welcome to this domain modeling session of a Clinical Decision Support System, or DSS. I am Olive and will be focusing on the detection of medication interactions, in other words, drug interactions. Coming from a clinical background, having worked as a frontline healthcare worker, medication safety is always a primary focus. Challenges come up when nurses struggle to double-check prescription before administering medications as they simply are not trained to have a strong pharmacology background. Being in high demand all the time also means health professionals don't have the time to research all the drugs for every patient's prescriptions. All these result in not being able to ensure a safer intervention process for patients, which is always one of the biggest fears for any health professional, is delivering something which we don't know enough about. On a daily basis, nurses are heavily reliant on clinicians or pharmacists to detect potential interactions, who specifically goes around to each drug chart to manually cross-check medications, which is naturally a time-consuming process. These knowledgeable staff are not always available, and especially after changes have been made to the drug chart or after office hours during a night shift, there are no one to consult with. And although with e-prescribing on the way to replace majority of handwritten prescription, the prescription software is not designed to detect or alert interactions. On the bright side though, it does question ambitiously high doses, which will hopefully reduce the amount of adverse events in the long run. And while some can argue that there are specific drug interaction software online or available in other countries, they may not have enough clinical relevance where patient details are preferably included for a comprehensive screen. Plus, they do require clinicians to go online separately, which can be impractical in the high-demand setting. There are mainly 4 types of drug interactions. In this domain model, we will be focusing on drug-to-drug interactions as they are easier to monitor with a set library of input values and have less changeable conditions dependent on patients' individual conditions. Here we have a mind map presentation of an overview of the structure of the drug-to-drug interaction detecting DSS contents. We will be looking into individual components within the data, events, and users categories, which will be explained in details later. Starting with users, these are the health professionals who may be involved in part of the medication prescribing, administering, and dispensing processes. As you can see on the top, prescribers are mainly practitioners, i.e. doctors, and some nurses who have prescribing rights, called the nurse practitioners. In the medical department settings, they are those who may require the DSS checkers prior to finalizing prescriptions. Administrators are those who give medication to patients, mainly nurses who might find this DSS useful when encountering unfamiliar drug combinations which they may want to cross-check before administering these drugs to patients. For dispensers, they are the pharmacists and hospital pharmacy who daily cross-checks as part of their routine. This DSS will hopefully help reduce some workload of queries or act as a virtual knowledge base when they are off work after hours. This drug-to-drug interaction detector is further narrowed down to medical departments and hospitals because medical specialties usually have repetitive combinations, although they are different between each specialties, such as again the cardiology or endocrinology departments. Given that this DSS can be customized to each specialty, the advantage is that the common drug combinations and even specialty-specific drug dose parameters can be set up to adjust alert frequencies, meaning there will be less over-reporting of potential drug interactions to avoid alert fatigue. On the whole, prescriptions generated from hospital are usually new or amended prescriptions for inpatients, i.e. the patient staying at hospital, or discharge prescriptions for the patients ready to go home. Input data mainly consists of patient details and prescription details. In the personal details section on the top, there are those information that can be obtained from the electronic health records, including patient's basic personal information such as the NHI, name, date of birth, and gender to simply identify a patient's profile, which can also be used as a tracking purpose. Also, the patient's medical history in terms of current admissions condition or diagnosis, regular medications and allergies are used for the DSS to detect any potential interactions between the current prescription and the patient's regular medications, which may not be on the inpatient prescription most of the time, or drug chart if clinicians are not aware or patients are not asked of such information. Allergies information extracted from the EHR act as a side function to detect any prescription errors, because sometimes allergies can also be missed when verbally asked at the bedside because patients can't remember or it's not documented originally in the past admissions. Vital signs, diet restrictions, and patients' changing condition are considered optional details because they are not part of the main formula to drug interaction detection. During this process, they do assist with clinical judgments. However, because they are so changeable depending on the patient's condition at the time of DSS use, the system will not be considering this as part of their main drug-to-drug interaction formula. Prescription details consist of basic entry of drug names, dosages, frequency, and route as required on all prescriptions. One of the potential challenges would be the differential drug names. Although countries do have standards of prescribing, clinicians often use differential drug names, brand names, and generic names in prescription, which can become confusing at times. This DSS can pose as a challenge to cross-check for handwritten prescription, but will come in useful in electronic prescription to synchronize across as a step prior to finalizing prescriptions. As some of the hospitals use medication dispensing system to help reduce medication administering errors, which involves entering drug names into the system manually anyway. This DSS can also be added as a side function for administrators to double-check before taking out medications for the patients. Upon processing input data, the DSS will have mainly two outcomes of drug interactions detected or no drug interactions detected. With no drug interaction detected in the system, DSS will remind users that results are for reference use only and it may not be 100% accurate, and only detects drugs-to-drug interactions, and that health professionals should not solely rely on the DSS results as final clinical judgment. If the DSS does detect potential drug reactions, it will display notification of drug alerts along with severity level of interactions. It will also provide suggestions for users to review prescription and displays common drug alternatives. Users will also be able to override or dismiss alerts and proceed with confirmation as per the no drug interaction detector pathway to finalize prescription or continue with drug administration. The drug-to-drug interaction detecting DSS will encourage clinicians to include checking of drug interaction as a daily common practice, with its design to provide higher clinical relevance by inputting EHR data. It should provide a more customized detection of drug combinations across specialties. For junior health professionals, this tool will bridge the knowledge gap without losing the efficiency in workflow in a fast-paced environment like the hospital. The floor staff, such as nurses, will be able to use the DSS as a first point of reference on the go when clinicians are not available to consult, putting another line of defense to medication errors such as described before. Pharmacists can also spend extra time for assessing other aspects such as tracking medication history or assessing patients' medication habits rather than being fully occupied with cross-checking prescription errors. Some limitations to the DSS includes the interoperability across different EHR and other DSS systems, because EHR systems do differ between cities or even district health boards. And with this DSS function designed mainly for prescribers and administrators, its ability to collaborate with those dispensing support systems or electronic prescription systems is questionable, where one size may not fit all. Drug labeling can also be quite different between cities, although prescription does still consist of the required drug name, route, dose, and frequency. There are a lot of drug combinations, and the risk of over-reporting of potential drug interactions is high when large proportional of the combination rules are not set up for the area of specialty, resulting in users' high rates in overriding and dismissals of alerts. Clinicians require tools that promote efficiency, and with this DSS being an extra tool on top of current healthcare software, it will need to be user-friendly and speedy enough so that the patients are not affected by this extra step to promote efficiency within their clinical settings. These are my references, and thank you for watching.